you all for being here tonight. Just a wave of introductions. I'm Michael Ricks, CEO here at St. John's. It's an honor for me to be here tonight with all of you amazing people, and thank you for being a part of this. I think this is our third or fourth time we've had this event. We have these little educational events. We've done it right here in the Jay and Mary Flaherty Commons Cafe, and again, thank you for taking time out of your night to be with us this evening. When I walked in, I saw Dr. Shemek Twardowski. You still here, Shemek? Oh, Shemek, I thought you left already. So, Dr. Shemek Twardowski, who is not on the panel because it's an all-female panel. Sorry, Shemek, for that. But I walked in, and Shemek was like, "I'm so glad to see another guy from St. John's, here tonight." And I said, "Me too." So we hung out together in the back corner there and didn't mingle with anybody but each other. But it's great to have you here. Actually, it reminds me when I was younger, in the younger days when I had my first child, a girl by the name of Jessica. We together went to a Kelly Clarkson concert. Little daddy-daughter date. It was amazing. I walked in and I was one of like 4 men out of 30,000 women and their little girls, which was also fascinating. So I've just had a little bit of nostalgia with that tonight as we gather. But I am grateful. It's an honor for me as a CEO to be able to participate and to be amongst such amazing women that we have that really add to the character and attributes of St. John's every single day, in addition to all of you that help support St. John's also. Obviously, you guys saw the title of tonight's event. I love it. It's worth repeating. It's called Empowering Women Fighting Cancer and Current Perspectives. But I'd like to offer a secondary theme tonight, and that secondary theme is called Even Better. Bear with me. All right, so the secondary theme is even better. So St. John's, for those of you that don't know, St. John's started in 1941, 1942. I always get that confused. One of those, don't fact check me, but 1942, I believe it is. And about 50 years after St. John's Health Center started in 1941, and about 50 years after that, St. John's got even better. And it got even better because we were able to have the amazing Donald L. Morton bring the John Wayne Cancer Institute from UCLA to St. John's. And then that even better theme continued in 2014. In 2014, the St. John's Health Center and the St. John's Cancer Institute got even better because we added at that time Dr. Melanie Goldfarb to our amazing St. John's Cancer Institute. And then in 2018, St. John's Health Center and the St. John's Cancer Institute got even better when we added Dr. Janie Grumley to the St. John's Cancer Institute and the St. John's Health Center. And then in I messed up. I messed up my chronological order. I'm surprised you didn't say. Excuse me. Back in 2015, which is before 2018, St. John's got even better when Dr. Ora Gordon joined the medical staff and the St. John's Cancer Institute. And then again, it's worth repeating because she's so amazing. In 2018, we got even better when Dr. Janie Grumley graced us with her presence here as the leader of our breast program. And then in 2021, St. John's got even better with the addition of Dr. Parvin Peddi, who joined us as well from UCLA. So awesome to have her. And then finally, in 2023, St. John's got even better with the addition of Dr. HyoPark. And so I'm not going into detail on these because that is what Dr. Ora Gordon is going to do, is provide a more appropriate and proper introduction to these amazing women physicians who truly, as I said at the beginning, have added to our reputation of excellence in a compassionate and caring way like only they can. So it is my pleasure to actually reintroduce her for the second time, talk about Dr. Ora Gordon. So Dr. Gordon and I have had the opportunity, much to her chagrin, but much to my pleasure, to get to know each other very well over the last year or so. We've known each other for about 5 years now, but it was my pleasure. When we were looking for an individual to help us continue the amazingness of what was formerly known as the John Wayne Cancer Institute, now known as the St. John's Cancer Institute, after Dr. Steve O'Day left, we were looking far and wide for that fabulous leader, and it took us a little while to realize that we had that fabulous leader right under our own nose in Dr. Ora Gordon. And so after much conversation, taking her out to the finest restaurants in LA, I got her after a night of amazing wine to sign the dotted line and to join and lead our amazing St. John's Cancer Institute. And so Dr. Gordon is our host tonight and our moderator, so please give a warm welcome to Dr. Ora Gordon.
Thank you so much, Michael. Always. It's hard to follow you. But, you know, tonight you stand out a little bit more than usual because you are surrounded by an incredible group of women physicians and a lot of women who are here. I really want to celebrate also the men who have come out to support and celebrate and to learn and to be there to learn and understand about cancer risk in women, for the women that you love and the women in your family. So I'm going to be brief in my introductions because in the handouts you have bios on everybody, and I really want to get into the dialogue and be respectful of everybody's time and the evening. So we're going to just run down the row of introductions for my incredibly esteemed colleagues here, who I have the delight and pleasure of being able to work with on a daily basis, and we touch patients' lives together as we navigate their cancer journeys, their risk, and trying to make all of the best decisions for them. First, so we'll start with Dr. Melanie Goldfarb, who is the Director for the Center of Endocrine Tumors and Disorders and is a Professor of Surgical Oncology at the St. John's Cancer Institute. All of the women here are leaders in their field and leaders at St. John's Health Center and as well in the Cancer Institute, and so it is of such an honor to be able to have this conversation tonight. Next, we have Dr. Janie Grumley, who is the Director of the Comprehensive Breast Program at the Margie Peterson Breast Center and Professor of Breast Oncology. HyoPark is coming in third there. She's a gynecologic oncologist. She is most recent to our staff and as part of the Institute. We are so happy to have her coming on board. She's already just been a fire of growth and opportunity. And last, but most definitely not least, and probably strong in that we're coming in as a closer there, is Dr. Parvin Peddi, who is the Director of Breast Medical Oncology and Therapeutic Breast Clinical Trials at the Margie Peterson Breast Center, and she's Associate Professor of Medical Oncology. So this is how the evening's going to work. I'm going to start off just leading each of them into a few questions to open up to really speak to their areas of expertise. And then I'm going to kind of get a little bit of a dialogue going on together and then open to the audience for questions. And I think if there are any housekeeping items, we'll just get a little flag up, but if not, keep thinking about your questions as the discussion goes on. You can jot them down and then we'll be passing mics. So let me begin. I think I'll start with, we'll go neck down. Okay.
That means I'm up first.
Dr. Goldfarb, so thyroid cancer and thyroid disease disproportionately affects women. Why is that?
All right, so somebody asked me this earlier, and I said they had to hang on for the answer. So it does, so thyroid nodules and thyroid hormone disorders, much more common in women. So you are correct in that part of the statement. Nobody's really been able to prove it, but everybody supposes it's because of estrogens and hormones that kind of go up when you hit puberty, and that's why all these things happen more in women. The thought, does cancer happen more in women than men? That's actually very much up for debate. So the incidence of aggressive thyroid cancer is the same in men and women, and the incidence in autopsy studies is the same, but women do seem to have more of these low-risk cancers. We don't really know, but yes. So stay tuned for this in 10 years.
So as we go through, I think you're going to hear a lot about hormone modulation, particularly in women, a little more unique to women. We certainly, when we do men's night, there will be diseases specific, particularly cancers in men, also a lot of hormonal drive that is different for men and women, but that's where the theme for tonight, I think, will be going through. So, Dr. Goldfarb, does everyone with thyroid cancer need surgery? And if so, we know anyone who's known somebody who's had thyroid cancer and has a big scar that sweeps their neck and they've lost their thyroid and they have to take hormone replacement for the rest of their life. Can you help address that answer?
I would love to, because that's one of my favorite questions. So for those of you that either know me or know somebody that's been to see me, my favorite thing is to tell somebody that they don't need surgery. So not all cancer needs the surgery, not all nodules need surgery, but many of them do. But where the field has come in years is the less is more approach. So even if you do need surgery, if we can save half of your thyroid, we try to do that. Now, obviously, as with you'll hear from everybody else, sometimes there's more aggressive cancers, more involved cancers, and then the organ needs to come out. But if it doesn't have to, we're really trying not to do that these days. We also, for small cancers like in men, which are here on Meds Night, we do active surveillance for small cancers. And what's coming down the pipeline, and maybe we'll talk about this later, is some newer ways to try to kill the cancer that don't involve surgery.
Terrific. I want to hear about those. Right. Dr. Grumley, I'd like your thoughts. Let's talk a little bit about breast screening and then about breast surgery. So we hear so many different guidelines, ages, when should you start a mammogram, how frequently should you have it? Can you help address that question for our women?
So I think the simplest answer that everybody should just go by is you should have a mammogram annually starting at the age of 40. The studies have shown that between 40 and 70, and that's where the studies, kind of looked at those patients, we see that we can save lives if we can find breast cancers early. Now, there's been a lot of debate as to whether or not it should be every year, every second year, what's your family history. There's so much that kind of goes along with it, but a lot of that is to try to ease anxiety in women. And so a lot of the issues that we had in the past is that women who have dense breast tissue, sometimes we can't see as well, and we have technology now that's available like 3D mammogram, ultrasounds that can help alleviate that, but also just understanding that a mammogram is not perfect. You might get called back, and don't get anxious if you get called back. If you understand that if you get a mammogram, we're looking, there's probably going to be at least one callback in your lifetime where we just need to have a better look or a better picture. There's no need to be anxious about it. And that's where, if we could alleviate and educate women about the anxiety that's associated with getting that callback and understanding that that doesn't mean it's a cancer diagnosis, it's just we're needing a better look. If you just go with that guideline of 40 and annually, it really covers everyone. Now, there's other people who, we may need more careful screening because of high risk factors or family history, and that can be kind of discussed with your provider or at our breast health clinic or our high risk clinic so that we can really devise the best screening plan for that individual.
And I think to follow up on that, maybe you can just talk about the lump clinic or the same day, when patients feel something or their partner feels something and there's suddenly a panic about something going on.
Right. So, as the majority of the participants here are women, you could probably attest to one day where you wake up and you feel something, or you get a breast pain, or you get some sort of symptom in the breast. And typically what happens is you'd have to go see your primary care doctor, and then they have you, make an appointment to come see them, and then you get some imaging, and then at the end of all of that, most of it is just, you're fine. You don't have anything. It's just a cyst or something. So what we've done here at St. John's is try to alleviate that kind of long loop. So we've decided we built a breast health clinic so that patients can actually have a direct access to a breast specialist, usually within 24 to 48 hours right in our clinic. And that way we can alleviate all of that anxiety. If you feel something, come in, we can look at it, we can assess whether or not you need imaging. If imaging is needed, we can get that done very quickly and answer that question. So we think of it as kind of like a rapid clinic in which we can actually take care of very specific issues very quickly. It is tied to our imaging appointments, and that's usually the biggest hurdle, trying to get an imaging appointment. I mean, I've heard so many patients say, oh, I need an additional workup, and they said I can come in 2 months. We never want to have a woman sitting there for 2 months waiting, thinking that they have something wrong, when in reality they probably don't have anything that needs to be taken care of, and we can address that right away. And if there is something, we can address it right away. We can get them into clinic and seen as quickly as possible.
Thank you. I think you'll be hearing a recurrent theme related to access, quality of life, mitigating the surgical burden, and then how to maintain somebody's optimal quality of life through the rest of their journey, whether it be with cancer or just living healthy throughout this evening. I'll give you one more question, then I'm going to move on. So if you do find cancer, and, thinking about the evolution of our surgical interventions for breast cancer, is mastectomy always required? I think most women will know now that it's not always required, but how does one decide, or how does it get assessed about mastectomy or mastectomy versus lumpectomy, and making those decisions, if you can address that a little bit in what we do here?
It's definitely a very individualized decision to be made, but in general, we have known since probably the 1990s that there's no survival benefit whether you do a small operation or a big operation. So survival is exactly the same whether we save your breast or if we remove the entire breast. And that's really important for people to understand, because I think most people have this misconception that bigger must be better, but it's very much like thyroid, sometimes less is more. And as we've kind of moved along, as our systemic therapies have gotten so much better, as our screening has gotten so much better, we've actually started to realize, and studies are coming out in the last couple of years that are showing women over the age of 50 actually have a better survival when they save their breast, as opposed to going on to a mastectomy. There's probably a lot of different reasons why people decide to have mastectomy, so that's why I do say it's an individual decision. But medically, if we can get the cancer out and treat you with all the systemic therapies that we need, you will do very well. We have to balance the risks of an operation with the benefits that you get. And for most people, the risks of a mastectomy and reconstruction and all of the operations that go along with that probably outweighs the benefit that you would actually get. So I think there isn't a right or a wrong answer. It's just trying to figure out what is the right thing for each individual person. But I think before you can make that decision, you have to actually talk through that decision, understand what the risks and benefits of each of those. And for most patients, a mastectomy is really not needed. And I know most women or most people wouldn't want to amputate something if you didn't need to. And so I think it's very much the same here in breast.
Dr. Park, I'm going to hop over you, just going to stay with the breast theme for right now. Dr. Peddi, let's talk about therapy for breast cancer, since so much has changed in this space. So, I think many hear that the treatment for breast cancer is so much better, it's better tolerated, women are just able to handle this, and there's so many more getting cured or living long, long times with remission even when they're stage 4. How would you kind of characterize this change in landscape, or how we're sort of approaching breast treatment from the oncologic side?
So treatment of breast cancer has changed a lot. Like from the time when we did bilateral mastectomies for everybody, radical bilateral mastectomies, and taking out the ovaries, and that's all that we had. So like the field of breast cancer is probably one of the most advanced fields of oncology today. And I can't even count how many drugs have been approved for breast cancer since I was in medical school. There have been that many. But it's not just the number of the drugs, a number of the treatments that have been approved, it's more how much personalized breast cancer has become. When a patient comes in now with breast cancer, I don't treat them all the same. I ask, what type of breast cancer is it? What does it rely on for its growth? How can I attack it? And now it's become as important to not undertreat and also not to overtreat patients with breast cancer. So we have genomic tests that can tell us if the patient needs chemo or not. And not everybody needs chemo, not everybody needs the same chemo. And there's so many targeted agents now that are approved for breast cancer. So you hear 1 in every 8 women has, at some point in their life has breast cancer. But the statistics that should be contrasted with is that only 1 in 40 dies of breast cancer. So maybe 1 in 8 will get breast cancer, but far, far fewer actually die of breast cancer. And that mortality rate has been very steadily coming down since the 1980s. So it's a very different field, very personalized, very advanced, and most of the patients that I see in clinic end up to being cured, which was not the case before.
That's so encouraging and should be for all of you. And we think about breast cancer, I think, is one that evokes so much fear in all women, over the course of their lives. So, there's a lot of excitement about immunotherapy, or if you want to think of, there's one therapeutic intervention that you'd like to talk about right now is just really being transformative within the field and exciting. I would love to hear about that. We do a lot of immunotherapy here, and we've been leaders in that space for a long time, but feel free.
I could talk all day just about that. So, cancer cells are not normal cells. Your immune system is supposed to catch abnormal cells. But the cancer cells have developed ways of evading this mechanism that your body has built in. They have masquerading markers on their surface that antagonize your immune system. So it's been our holy grail to try to train the immune system to catch these cancer cells that are abnormal and should be caught, but are somehow evading. So several fields of oncology, including breast cancer, have now found a way in at least some patients with breast cancer to give immunotherapy drugs that can then unmask these tumor cells for the abnormal cells that they are, and then this, the chemo can actually kill these cancer cells, and immune cells can kill these cancer cells. So it's been transformative. And vastly improving the survival of these patients. And that's an area that we're continuing to work on, and St. John's has been a leader in melanoma, as well as breast, and several other fields of oncology.
Prostate.
And prostate, yes.
Shout out.
Yes.
Turn you on to the back. Okay.
Yes.
Let's move below the belt. Dr. Park. How effective are current screening methods for gynecologic cancers, and what can women do for prevention? It's a space where there's a unique opportunity.
Thank you for the question, and I just want to echo Dr. Grumley in encouraging women to get mammogram screening starting at age 40. There's been a lot of mixed messages, I feel like, across the different specialty fields, and when to start screening. I just want you guys to know that the Society of Obstetrics and Gynecology have always maintained and never wavered on the fact that women should start getting screened age 40. So when in doubt, I'd listen to your OBGYN doctors. But the current screening efficacy really varies by the type of cancer we are screening for. Of course, when we're thinking about cancers of female reproductive organs, we're largely thinking about endometrial cancer, ovarian cancer, cervical cancer, vulvovaginal cancer. With cervical cancer, our current screening program is excellent. It's one of the most successful cancer screening programs there exists, and it's been vastly. It played an incredible role in early detection of precancerous lesions, in decreasing the incidence and improving survival outcome. So Pap smear screening, as you guys are mostly familiar with, should be initiated at age 21. Now, technically, by the current guidelines, you can exit screening as long as you've had normal, routine, and screening for the past 10 years. At age 65, what I always stress to the patients is that it doesn't mean that you can stop getting pelvic examination. A full pelvic gynecologic examination requires a full visual inspection of your vulvovaginal region, because you could develop lesions on the vulva area. You could even develop melanoma of your vaginal tissue, where people are always looking. Ultrasounds, transvaginal ultrasound does not replace your doctor doing a thorough visual inspection. That's just something I always want to stress to my patients. But if you are routinely getting screened with Pap smears and HPV testing, we can nearly completely prevent advanced cervical cancers. And of course, from a prevention standpoint, now we have a very effective vaccination program against human papillomavirus, which is the main cause of cervical cancer, as well as majority of vulvovaginal cancers as well. So we encourage all our young patients. It's the most effective if you get vaccinated prior to the HPV exposure. HPV, human papillomavirus, of course, is the most common sexually transmitted infection across the world. By and large, your immune system will clear the virus on average about 12 months. 90% of the patients with a healthy immune system will clear the virus in 2 years, but those lingering infections sometimes can cause enough DNA damage to the cervical, vaginal, and vulvar cells that can, over time, transfer into premalignant cells and invasive malignancy. So getting vaccinated significantly decreases the risk of these cellular transformation into pre-invasive and invasive cancers. Even women who have been exposed to HPV infections in the past are also eligible and will benefit from HPV vaccination, and current FDA approval, which was initially between age 9 and 26, has been extended years ago up to age 45. So if you have not been vaccinated in the past, it's certainly something to consider talking to your primary care physicians about. When it comes to endometrial cancer screening, a combination of ultrasound and endometrial biopsy, which can be performed even fairly easily in an office setting, is usually quite accurate in detecting pre-malignant and malignant lesions. And of course, endometrial cancers tend to have early symptom manifestation in that it will cause abnormal bleeding, abnormal discharge, pain. So any degree of abnormal bleeding, after you go through menopause, should be considered abnormal and should be thoroughly evaluated, including ultrasounds and endometrial biopsies. Ovarian cancer is the tricky one, of course. We don't have a very accurate way of detecting ovarian cancers early. The symptoms early on, even though we like to educate our patients and encourage patients to be advocates of their own health, even if the symptoms seem a little bit vague and can easily be dismissed, to seek care early and to be thoroughly evaluated. But the early symptoms can be really quite challenging to diagnose, and currently existing diagnostic modalities such as tumor marker testing like CA-125, ultrasounds, even CAT scans and MRIs can sometimes be not as useful in detecting ovarian cancer early. What I think is exciting development in our field going forward, although it is not, a lot of research needs to be done and still in the more developmental phase, is the kind of advent of circulating tumor DNAs. Now, these are fragments of tumor DNAs that can be detected through blood draws that may give us that information early with ovarian cancer. So that's currently being an active field of research, and I think it's very promising that may be a main part of ovarian early cancer screening and detection in the future.
So you give me all these ideas. I'm going to do a one-woman show on the cell-free DNA and the blood cancer, because I run one of the biggest clinical trials on using this blood test to detect either one cancer or up to 50 cancers with just one blood test. So we will do another night on that for sure. The other thing that I realize is that, a lot of the things that we're talking about, we say until age 70 or after age 65 you don't need, and whatever. And so just for those of you who may have a few silver hairs and maybe are in that demographic, it is not because we say after that we expect you to check out. It's some of it is just to do with epidemiology, and some of it also just has to do with, that when you get to a certain age of maturity, you've outrun a certain amount of risk, and then you face forward to a different kind of risk. And so we want to modify and individualize at every point in somebody's life, what do they need in terms of their best screening, what is appropriate for them. Sometimes it's an increase in screening, sometimes it's a diminution in screening. And so when somebody says, you don't probably need a mammogram every year anymore, it's not because they're signing you off. It's because they're saying the risk benefit, the likelihood of us being able to find something is equal at this interval as it is at another. And the same goes for colonoscopy and other kinds of things. So just know that when you have that dialogue and where this data comes in, it's really always looking on a population level, what's the best thing, and then for the individual, we always want to kind of individualize and refine that. And all of us, when we work together, I think that's what we do most importantly, is to say everybody is an individual, and how best do we manage each of you. So let me, get a little discussion and maybe a little bit of debate going. I'm going to just throw one more thing in there for Dr. Park related to prevention, because I run the hereditary and high-risk prevention programs, and so I do a lot of modalities to try to prevent people from ever getting cancer or detecting it as early as possible. One other thing that I just don't think gets discussed enough is that hormonal contraception is highly protective for ovarian cancer. So in women who are at elevated risk, if over the course of their lifetime they have used 5 years of contraception for medical contraception, we won't talk about for whatever. I don't want to think they come down at me. For medical prevention, you reduce your risk by 50%. It is one of the most powerful preventive agents that we can give for anything. So please, for those of you who are at risk, who have daughters who are at risk, just know that this is part of a conversation that, again, when you go to your gynecologist, when you go to your primary care, when you're talking to your breast specialist, that this should be incorporated into decision makings based on that risk. Okay, so for every woman in the audience who is approaching or in menopause, the most common concern maybe all of us here, and certainly that I hear, is about hormone replacement therapy or menopausal replacement therapy, to do or not to do, how long to do. And even for thyroid replacement, women who are feeling like their metabolism is getting sluggish, or they're getting a little extra weight, all of these kinds of things in terms of decision. So let me open the floor and just say, how do you counsel women on risks and benefits related to hormones? Anybody?
So I can go ahead and then we can go along. So, women used to get hormone replacement for everything. Like as soon as there was a little bit of a hot flash, it's like, oh no, this is part of the thing. This is what everybody needs to be on, and everybody was placed on hormone replacement. And then we had the big national study, Women's Health Initiative, that found that there was increased risk of breast cancer with hormone replacement therapy. Then the pendulum swung to, no, nobody should be on hormone replacement therapy. Absolutely not. Under any circumstances, at any age, nobody should be. The truth is probably somewhere in between, that women who have very significant menopausal symptoms and who are young, that's the other key part of it, like in their 40s or maybe early 50s, and they don't have other risk factors. Obviously, they've never had breast cancer, and they're not at high risk because of genetics or what have you. It's very mildly affecting their breast cancer risk if they are placed on hormone replacement therapy. But as you get to your 60s and 70s and 80s, if a woman continues to be on hormone replacement, then the risk of breast cancer really goes higher. And that becomes much more of a risk. And thankfully, the time when women mostly need it is the earlier ages too. So I think of it as a discussion between the patient and their doctors, and there's no one absolute answer. At least that's how I discuss with my patients. But please.
I would say that I am probably a stronger proponent of hormone replacement therapy.
Because I see the breast cancer.
Women's Health Institute study, which made everybody flush their hormones down the toilet overnight. After the fact, we are, realizing that there was a lot of, not a problem, but reason why that those results were seen. Increased risk of breast cancer, increased risk of cardiovascular events. A majority of women who were receiving hormone replacement therapy in the Women's Health study were significantly older, typically age 65 or older, and they were on more kind of older form of hormones, which were kind of conjugated equine hormones, much higher doses than were typically given in a bioidentical fashion currently. So I think that's where kind of the pendulum has swung. And now more mounting evidence of data, to me, is more convincing to me that for majority of women, hormone replacement therapy is the most effective way of treating perimenopausal and menopausal symptoms, and can be done effectively and probably for longer term than, we typically think about. Certainly lowest effective dose for, the shortest duration still is something to be considered. That we're getting more and more data to suggest that long-term hormone replacement therapy is good for your, not for only for your bone health, but also for cardiovascular health, especially if it's started early, and also very important for your cognitive health long-term. And if the estrogen dose is used at a lower dose, and then unlike more traditionally when it was given more orally, it's given in a more steady fashion, like in a patch, or sometimes even more topically, or in a pellet fashion, modulated with different types of progestin therapy, because we're now learning that different types of progesterone and progestin also affects your kind of long-term health and health risks and benefits. I think for most patients, we can offer hormone replacement therapy effectively long-term, past even the age 65. If you ask a gynecologist or gynecologic oncologist, when should you stop when should you stop hormones, we say about a week before you pass.
Well, now that I've been living here in Santa Monica, I kind of have to agree with that, because I see a lot of women who do come in on estrogen replacement, and man, they look great. Like, as I get closer to that 50 and 60, I think I might want to take up a little bit of that. But in reality, I think it has to come down to risks and benefits, right? What is your risk? What is your benefit? If you're suffering every single day and you don't feel like yourself, you're foggy, you're depressed, you're like, everything is terrible when you're not on hormones, then to me, it's like, go on your hormones. I can screen for your breast cancer, right? We can do things. We can do oncoplastic surgery. In 10 years, we'll do another lift. And, there are things we can do about your breast cancer. But if you feel terrible every single day, it's just going to feel like you're living longer. So I think it has to do with the risk-benefit ratio. It has to be talking about, how do you feel when you're off of it? How do you feel when you're on it? What is your breast cancer risk? Did you have just a little bit of DCIS that we took care of, or did you have lymph nodes that were positive from your breast cancer? Those are very different things. So we can't really blanketly say hormones is bad and you can't be on it. It's not a good or bad. It's just a figuring out what is the right thing for you, and that's why it's such an important thing to get to know your patients and have dialogue and talk through all of those kind of risks and benefits before making a decision.
So I'm just going to say one thing. So we hear about all these complaints. They're all menopause, and here's all these doctors that are like, yeah, that's your menopause. But every patient that comes into my office is convinced that every one of their problems is caused by their thyroid. So, be nice to the thyroid. Most of the time, it is not the cause of your symptoms and problems. But we don't more talk about replacement. It's actually a very easy thing. You either need hormone or you don't. Tweaking it is a whole nother issue, which my lovely endocrinology partners do, and not me. But whether you need it or not is much more clear cut. That's based on your labs. But it is kind of like the hormones. It needs some tweaking. Some things or combinations work for some people, don't work for others. So, needs a little bit of work.
Dr. Goldfarb, that's because when they think that everything's because of menopause and we don't think so, we said, maybe it's your thyroid.
You should go see that.
I wonder my clinic is so busy.
I also want to, just for our audience, when the linkage of hormone replacement therapy with increased risk of breast cancer, it's really only been established for patients who are on combination hormone replacement therapy. That includes estrogen and progesterone. Estrogen is really what you need. That's what's treating your menopausal symptoms. We have to combine it with progesterone to protect you against endometrial cancer risk. Because past menopause, you're no longer naturally producing the progesterone, and then the overstimulation of your endometrial cells from the estrogen can cause increased overgrowth, DNA mutations, pre-invasive and invasive cancer. And that's why we need to give the progesterone. When we just look at women who are just getting estrogen replacement therapy alone, because they've had a hysterectomy or what have you, we actually do not see an increased risk of breast cancer unless, of course, they've had a personal history of breast cancer. So I want to say that point. And then there are different ways of doing progesterone therapy. Actually, I believe that instead of doing systemic therapy, if we do more local progesterone therapy, such as a hormone-releasing IUD, which is just an intrauterine device, it's a local, gives local protection to endometrial lining. Actually, in fact, it is a stronger protector of endometrial cancer compared to systemic oral progesterone, whereas the systemic absorption from the IUD to the rest of your body is really quite clinically negligible. You get the maximum benefit of the progesterone from the estrogen and really minimize the downsides of the progesterone use, and also more effectively prevent endometrial cancer.
Yeah, that's something that we frequently recommend for my high-risk patients. But however, Dr. Peddi looks like she's going to jump up and she's going to take off her shoe and she's going to whack you. Because but you can see that very much it depends on what your risks are and where you are in your stage of life, and kind of help make those decisions and make those the best decisions for you, and why we always take really a team approach, and that there's a lot of dialogue and there's a lot of answers. One thing in medicine is nobody can ever say always or absolute, because if they do, you should walk out, right? Because that's just not the way medicine, that's the way medicine doesn't work. And if you're taking, like, my team in the back, we're definitely having, like, instead of the silver singles, we should just do, like, silver season health or something. I think we really need, an evening devoted to the care in our age of maturity, because it's different, as well as really addressing the transition from young adulthood into, middle adulthood. Okay, so let's just close this part of the session with all of your thoughts on kind of exciting advances in clinical trials, anything you want in future direction. Just give us like a hot topic. What do you think is like just coming if you got it, and if not, we'll open the audience and get to that. Is there something that you're working on in a research trial right now, and how does that support our patient's journey? Are there any emerging technologies or therapies that are super exciting to you in the field now or in the future? And then how does the community support research and patient care in your field, for all of us together, for women, and really for protecting lives? And is there anything you need for kind of keeping your program on the leading edge? So any of those, I'm going to reverse the order. I'll just start with Dr. Goldfarb, and we'll run it down. You got?
That's a lot to talk about.
No.
I could do like hours.
No. You get to pick one.
I get to pick one.
I would never let you have 5 things that you could answer.
Because I don't talk at all. So I think, to me, the most interesting thing in the field of thyroid is where we talked about this non-surgical treatment. So something that I brought here almost 3 years ago, we were the first Providence hospital and one of the first on the West Coast, is to do something called thermal ablation for your thyroid. So that's something we do in the office. No anesthesia, no nothing like that, no scar, no surgery. That we stick a needle in you, and I call it zapping. But basically, we're using thermal ablation to kill tumor cells in your thyroid and shrink them. Now, for the most part, we've been doing it for big benign nodules, but as more studies have come out in Europe and in Asia long term to use it for small cancers, we're going to start introducing that pretty soon. So another option to watching small cancers will be for people that are like, ooh, I don't like the idea of having a cancer in me. I want it gone, but I really don't want surgery. We will be able to zap it in the office and kill it and get rid of it. And I think as we get better and better at this, we'll be able to do that for larger cancers, not for everybody. As with, some people need a mastectomy. Some people need their whole thyroid out. That's just, it is what it is. But if we can do less for more people, that's how we're going to keep advancing the field.
Dr. Grumley.
Is this one? Okay. Yeah. So I think there's lots of exciting things. Breast cancer is one of those areas where there's always research happening. But one of the things that I'm kind of excited about that we're bringing over here is one of our alliance trials that's actually really looking at finally the cognitive function in women once we take away their estrogen and when we block their estrogen. I mean, we hear endless number of women who come in and they say, I just got this fog and I didn't have chemo, but I can't think of that name, I can't remember anything. And so there's a trial that's actually a national trial that's looking at testing women after breast cancer and looking at their cognitive function. So we're trying to test everyone for their cognitive function, whether you have endocrine therapy or not, so that we can track who's actually affected by it. But the trial is really great in the sense that they're actually doing some early interventions. So they're trying to see if we could train your brain a little bit, do some brain exercises to see if we can actually alleviate it, not take you off the medication necessarily, but to try to have early intervention so that we don't have cognitive impairment with that. So I'm really excited to be able to kind of start that here and really use the technology and hopefully help the women who we do have here in our clinic. So.
Dr. Park? Or, no?
It's almost unfair because there's just so many different types of gynecologic cancers. I will say, just to echo, your field, I'm really excited about, studying and developing circulating tumor DNA and cell-free DNA. Screening, not only as a screening tool, certainly in ovarian cancer side, we're very excited about that. Once, you develop ovarian cancer, we have a fairly sensitive marker. In the majority of the cases, a tumor marker, CA-125, is a fairly sensitive marker to follow for, treatment outcome and recurrence. Endometrial cancer, we don't really have that. Our early detection is fairly, we have good outcome that way, but detecting recurrence, what do we do? Do we just put these, relatively young women through a series of radiation exposures or a series of imaging? That in and of itself is a risk. We don't have a very good non-invasive way of screening for recurrences, so I'm very excited about that with endometrial cancer. And then just one thing more to add, just because my love is a robotic-assisted minimally invasive surgery, that's something that's one of the earliest field that started utilizing this technology was in the urology and the gynecology division. So both Dr. Lane and I, throughout our career, we grew up with them, more than really anybody else. So now everything in the treatment, both in the surgery side and systemic therapy side, is becoming personalized and precision accuracy while minimizing the morbidity of the treatment, whatever modality it is. So using robotic-assisted technology now with the next generation of the robot is starting to incorporate artificial intelligence and specialized imaging capabilities. And we're currently also studying how do we localize active cancer cells that we can actually detect real time during surgery, and we combine that with all the forthcoming capabilities of this amazing platform. I'm really excited that we'll be able to offer precise targeted surgical therapy for patients who traditionally required large radical open surgeries.
Who knew that like a generation of Call of Duty and Mario Brothers was going to lead to like these amazing robotic surgeons? So, it all comes up good and good. Dr. Peddi.
Just so much for breast cancer to talk about. So probably the most I'm excited about is a new generation of smart chemotherapy drugs. So chemo kills any cell that divides, right? So it doesn't differentiate between good normal cells and bad cancer cells. So these so-called smart chemo drugs, you have the chemo drug that is pretty toxic. You link it to a marker that is only found on the cancer cells, and then you infuse this one thing as a whole to the cancer patients. And when the whole drug finds the cancer, only then we say it delivers the payload, and the chemo goes inside the cancer cells, and it basically exerts its effect. So then you have less side effects. You may not have any hair loss. You may have far less nausea with these chemo drugs and much more targeted. So in our national conference this month in Chicago, we had a smart chemo drug called Enhertu show to be so effective at finding these markers that are called HER2 on cancer cells that it can now even treat patients who don't have what you define as HER2 positive cancer. They have so little HER2 on the cancer cells that they don't even qualify for the traditional anti-HER2 drugs. But this drug is so smart and so targeted, they can find that little tiny HER2 and be able to fight the cancer cells. So that's the holy grail for oncologists. That's one. And I would say, like, just in general, personalized medications that are targeting specific mutations in cancers. So every patient that I see who has advanced breast cancer, they get next generation sequencing of their whole genome of their cancer to try to find out what are the specific mutations that only this person's cancer has, and then do I have a drug for that? And to be able to personalize it for that particular patient. And we have new imaging studies. I could go on and on, but it's amazing. It's a very, very good time to be able to be part of this field, because they're just very good things that are coming every day that are being developed for breast cancer.
Dare I say it's a great time to get breast cancer?
At least better than 30 years ago. Time to get breast cancer.
Of course. All right, so we're going to open the floor to questions. So there are going to be mics to pass around for anybody who has a question. The only thing I would ask is, if you have a question, please keep it sort of general to for the whole audience, as opposed to sort of an individualized question for yourself, because we can't provide medical counsel on this. And really appreciate so much, everybody, just your attention thus far. So please, if you have a question. And I just want to say, in this dialogue, and there's somebody up front who has a question, if you want, Morgan, is that, in addition, here you have, these incredible physicians involved in women's cancers. We have a whole Women's Health Institute for our non-oncology based care, for the treatment of urologic diseases, for pelvic health, for continuity in terms of care. We have a brain health program that is extraordinary in terms of helping people optimize their cognitive function, whether it be after cancer, during whatever, or just part of natural aging or something else. I, of course, think that genetics is the answer to everything, and so I'm really pleased that we all touch on that. But of course, from hereditary, from individualizing risk, we're just there for you in cancer, in cardiovascular disease, and everything. So let me just open the floor, and if you have a specific physician that you want your question to, or just open to the group.
Okay, this is a question for Dr. Grumley. So what determines when a woman comes in and has a mammogram, whether she then needs to have other procedures, like ultrasound or MRI?
So I think what you're asking is if they need additional screening in addition to a mammogram. So everybody gets a letter that says you're heterogeneously dense. I can almost guarantee that everybody's mammogram says that. And that's because, really, lawyers dictate that we have to say something about it. Women need to know if they have heterogeneously dense or very dense breast tissue. It doesn't mean the same thing. Very dense is very different than heterogeneously dense. So now that we have 3D mammograms, we can definitely see through a lot better some of the density. And most women who will also tell me, oh, when I was 40, they told me I was dense. I'm now 75, I'm still dense. Well, not necessarily. The density of your breast changes as you go through menopause. So just because you were dense at one point in time doesn't mean you're going to be dense for the rest of your life. What we like to do is I like to kind of show them the picture and show them exactly what we're looking at. What's hard about dense breast tissue is not that you're at higher risk of having breast cancer, it's harder to find breast cancer. Your background is all white. It's really hard to find something that's white when your background is white. In that situation, ultrasound is a really helpful tool. You can actually help see, it's like looking at the same thing from a different angle, right? So looking at it in a different way. So if you do have very dense breast tissue, an ultrasound is a really great adjunct to that, and we want to add that to your screening so that we can help detect things, because it's hard to see through your mammogram. The other thing that's important is that when you do come for your mammogram, if you're feeling something, you have to let us know. You can't just say, oh, I'm getting my screening mammogram, so it'll be fine. If you're feeling something, that automatically dictates that you need additional workup, not just the screening mammogram alone. And so a lot of women will come in and say, well, my mammogram was normal, but I felt this thing and they didn't see it, so I thought it was nothing. Well, it dictates if you feel something, we need to actually work it up with a diagnostic. So you need to speak up when that happens, because often we will miss things if you have dense breast tissue and it wasn't properly worked up. So very dense breast tissue needs, we do recommend adding an ultrasound, bilateral ultrasound. We've got ABUS now, thanks to some very generous donors through the Women's Health Institute. We have an ABUS machine, which is an automated breast ultrasound. It makes it so much easier for women to be able to get a reliable ultrasound, so it's readily available. But if there's any question about the density, just ask either your physician or even ask us at the breast center. We're happy to kind of help tailor to what it needs. Now, as for MRIs, that's a really good question. Almost everybody's like, I don't want a mammogram, I don't want the radiation, I'm just going to do MRIs every year. Well, the reason we don't screen everyone with MRIs is because MRI is a very sensitive test. That means a lot of things show up on an MRI, but it's not always something that we actually need to take care of. So MRI uses blood flow to the breast. If you get it at the wrong time of the month, if you do it just at the wrong time of your cycle, your breast will light up like a Christmas tree. Right? So it's blood flow to the breast. So it's very different in the way it looks at things. Now, if you're high risk, we want to screen you with an MRI because you're at much higher risk of having a breast cancer. So we want to find a lot of things. Even if it's nothing, we'd rather biopsy it just because your risk is high. But if you're of average risk, adding that MRI to it will probably just mean you'll end up getting more biopsies and more anxiety and more fear because we're finding things that may not turn into anything that we actually needed to worry about. I just had a patient just came in today post-op. She had an MRI because she was worried, and she had this area, the blood flow. She was worried about it for weeks and weeks. We took it out. It was just nothing. Right? So again, she's like, but should I get it every 2 years? I'm like, you want to go through this every 2 years? Right? Obviously, you have to balance those things. You have to understand what your risk is and what your benefit is from whatever screening. If you do have a genetic predisposition, an MRI is absolutely part of that screening because we want to make sure we don't miss anything in those patients. But definitely talk to your physicians, walk through your images, have a look at them. It's really easy to kind of just pull them up and look at them, and you'll know what dense breasts look like and what your breasts look like.
Thank you.
Right behind.
I think this is for Dr. Park. You mentioned something about vaginal or vulva melanoma. What? I've never heard of that, and is that something we should be searching on ourselves for, or what is that?
Yes, you can actually develop melanoma in any part of your body, even inside of your mouth and inside of these mucosal surfaces. Those are called mucosal melanoma. Usually difficult to detect because we're not always searching for these areas. These are not always due to, as you might imagine, what we classically imagine to be sun exposure related. But yes, for those reasons and many other reasons, I always encourage women to just become familiar with their body. Always know what your skin, looks like. If there's any unusual lesion, please advocate for yourself and ask your provider to take a close look at it. Melanomas, unlike other types of squamous vulvar premalignant lesions or malignancies, which are typically HPV, human papilloma virus derived, can progress quite rapidly. So melanomas can look like just kind of a bluish pigmented lesion on the vulva area. Maybe a mole, maybe nothing, maybe a blood blister. Sometimes, because they're so rare, even, gynecologists or specialists sometimes look at it, oh, it's probably normal. Let's see you back in 3 to 4 months. And 3 to 4 months, in that time, the lesion has significantly grown, whereas we wouldn't expect that with other types of lesion. So pay attention to, and oftentimes you won't have significant symptoms other than maybe a little bit of irritation, itching, burning, but pay attention to, the look and the size of the lesion, and certainly anything that doesn't go away on its own or is progressing or changing in any fashion needs to be biopsied and looked again.
I think there was one over here, and then we'll just take one more question. But if there's a gent who has a question, I'll take
Hi.
Tiffany take priority.
This could be for everybody about prevention and the environment and diet and nutrition and stress and depression and emotional health. Do you look at cancer as related to all of those components as well? or not?
I don't think you can definitively say, right? I mean, everybody has stress in their lives. Breast cancer is a common cancer. Does your stress directly cause your breast cancer? I don't know of any good studies that actually can definitively tell you that. Now, is stress good for you? I would say no, stress is not good for you. So I think focusing on a good, healthy lifestyle is all we can advocate for, right? Making good choices when it comes to diet. There is no, cancer diet. I just want to say that. There is no diet out there that will prevent you from getting cancer. There is no such thing. So live a really healthy life. I mean, do the things that's going to make your body feel good, nourish it, exercise, do all the things that, we know is good for our body and take good care of it. And I think even patients who have the perfect diet, perfectly vegan diet, who exercise all the time can still get breast cancer. So it's not this magic thing, and it's probably because there's multiple reasons why somebody could develop cancer. We can't mitigate all of them. And I feel like, at least for breast, one of the largest reasons, or one of the biggest risk factors for breast cancer is just getting older. So unless somebody's come up with a cure for aging, I'm not sure we can totally mitigate it, but we can try to minimize it.
So I was just going to add a few points. So one, I wholly agree with Janie. I don't think there's any data out there that there's a diet or a way of living or whatever that's going to prevent cancer. Where I will say all this stress and nutrition all comes into play, I think, is from the time you get diagnosed, you are a survivor. So we have also in our audience kind of the head of our survivorship psychosocial program that I kind of started here a long time ago, passed on the reins, so it's very near and dear to my heart. But I think all that stuff becomes ever more important in that after, and how you live with your cancer, how you function, what your new normal is. And so I think all that stuff becomes really important. There is some not great data for certain cancers that maybe things could affect recurrence, and I'm not going to get into that, but there is some thoughts out there. So I think it's really important for the after, but not as much in the before.
Yeah. Well, here's another night we're going to need to do on nutrition and intervention prevention, because I would argue that absolutely that there is a role for primary prevention with nutrition and with supplements and intervention. And I took a whole fellowship in integrative medicine as a medical geneticist because I needed more tools to help women and men to prevent risk and to prevent cancer. So, we need to probably close for now, and I would like to, but Dr. Peddi really looks at
Two sentences.
Just two sentences.
I was just going to say, don't stress about the stress. That's number one. I tell my patients all the time, I completely agree, the stress is not going to cause cancer. So don't stress about that. And the one thing about diet, I would say, alcohol does increase risk of breast cancer. Mm-hmm. That's the one thing about diet that we do know there is a correlation. With increased alcohol consumption, there's higher estrogen production in a woman. So that's my...
But it's not, it decreases stress sometimes.
Exactly.
I agree. So if it's needed for that, then that's different. Yeah.
But I think it's, now I don't want people running out there going, I had a glass of wine tonight, so I'm going to have cancer. So that's not the equation, right?
It's not like you can't drink at all.
Anything in excess is not good for you. There are no bad foods, but there are really bad amounts. And I think overindulging in anything is a problem.
Well, I'd say a category 1 carcinogen like a hot dog is probably something you can just avoid all the time.
Right.
So that's why we're going to have another night to talk about this. Okay. So I think with that we'll close, and I want to call up Dr. Sheryl Bourgeois to close for us for the evening, and then really we'll just mingle. And thank you all so much for your attention and time.
Well, we had an earlier one of these education nights, and it certainly was not as lively. It was equally informative, but that was really amazing. But I could have gone without the message about the alcohol, Dr. Peddi, as I just finished a glass of wine. As we draw to a close, I just want to extend my deepest thanks to all of you for coming out tonight and showing your support for cancer education and also in empowering women. We have a lot of familiar faces tonight. I just want to point out a couple of people that are here. I do want to point out that our chair of the St. John's Health Center Foundation, Gretchen Willison, is here. Gretchen, would you mind? I also want to mention we have an event coming up in the fall. It's called Power of Pink, and it's dedicated to cancer education. In particular, it supports the Margie Peterson Breast Center, helps us to provide a lot of the research we talked about tonight. It also helps to support a fellow. And I just want to call out co-chair Ellen Whiteman, and I think we have a couple of other committee members. Please, thank you, ladies, for coming. They're already actively working on that event, so if you want to know about it, those are the two ladies to talk to tonight. A night like tonight, I think, really reminds us just how fortunate we are at St. John's to have leaders in this field, some of the brightest minds dedicated to women's cancer. So I want to start by thanking our moderator, Dr. Gordon, and our amazing esteemed panelists, Dr. Peddi, Dr. Grumley, Dr. Park, Dr. Goldfarb. Thank you all. I think one of the other things that tonight's event does is it points out and highlights one of the factors that I think really distinguishes St. John's. And that's, these physicians are active researchers. They are active learners. As you heard, many of them citing clinical trials as they were, talking and responding to your questions, as well as being dedicated clinicians. They are devoting a great deal of time, not time that they take from their patients, to advocating in their fields and advancing their fields, to participating and co-authoring articles that appear in some of the most respected medical journals in the world. They attend conferences all over the world. I mean, they are held in the highest regards, not just here, but around the world in their field. And these kinds of pursuits, this kind of work, is really, it's not uncommon in places like UCLA or USC or Johns Hopkins, places like academic medical centers. As you heard, many of them came from academic medical centers, and they came by choice to St. John's. It's uncommon to have this kind of individuals at a community hospital. And that's what is truly special about St. John's. That's what's so extraordinary about it. But I think what makes it over the top is that these are dedicated clinicians that, provide compassionate care. They go above and beyond for their patients. They collaborate. they're kidding one another today, but I've heard about so many cases when diagnosis is made and they're walking, a patient from their office into another person's office. They don't make a patient wait to go home and then come back for a different test. To me, that's really something that you just don't find. That's certainly not common in academic medical centers. And so I just want to point that out. And I think we need to give these fine physicians another round of applause. I know that many of you in the room, I see a lot of familiar faces. I know many of you already support St. John's, support the specific work that's offered by these amazing physicians. And I just want to say thank you. I represent the foundation that raises funds to support St. John's. And philanthropy really is making the difference. It is bridging the gap to what is possible, to the new discoveries, to the new treatments we heard about tonight. And so I just want to say thank you for being interested, being active, coming out tonight. The evening's not over. There's plenty of wonderful refreshments in the back. I know there was questions that still needed to be raised and asked, and I know our panelists are here to answer those questions. Thank you for coming out, and we hope you'll be back and learning more. Thank you so much.